Okay, so while we're waiting, one of the things that I will mention is that we do have an open Q&A tonight. So if you have any questions, please use your Q&A on the Zoom platform. You'll notice there's a button down below that says Q&A. You can click there. Great way to ask your question. Basically what that does is it actually gives us a recording of your question. So if there's, for some reason, we're not able to get to your question tonight, we will try to get to all your questions. But if we're not able to get to it tonight, we will email you back very quickly and get you an answer to your question. We also have the chat, so you're free to use the chat as well. So we have a very special guest on this evening. We're excited to actually have Leslie Stevens with us. Leslie is a wealth of information, so I know that you're going to really enjoy her presentation. Tell you a little bit more about Leslie. She's actually been involved with the world of pediatric sleep, breathing, and airway for over 35 years. She's an international trainer and lecturer. More importantly, she's a mother of 3. Her goal and desire is to provide every advantage for children to allow them to live healthy and happy lives. One of the things that you're going to learn tonight is that there is a silent epidemic affecting 9 out of 10 children, and this epidemic manifests itself in a variety of symptoms that can be easily overlooked and, most unfortunately, left untreated and misdiagnosed. It's absolutely critical that our children are evaluated for sleep and breathing habits. Leslie's not only our fearless leader, she actually, I don't think there's a question in reference to the subject of pediatric sleep, breathing, and HealthyStart's connection that she cannot answer. And, really, when you have the backing of a company like HealthyStart by Orthotane, you have over 51 years, you have over 4 million cases, and you have tons of research to back you. Leslie's mission is to educate both parents and dental professionals to ensure children a lifetime of health, happiness, and success. So we're excited to have Leslie with us. And at this time, I'd actually like to hand the floor and the mic over to Leslie Stevens.
Well, thank you, Susie, so much. And I am so happy we have such a big group today. And I love this. I absolutely love talking to all of you, providing you with really some incredibly important information about sleep, breathing, and airway. It's amazing everything that is connected to the airway, breathing, sleep, and knowing that no matter if you're a orthodontist, a dentist, a pediatric dentist, a myofunctional therapist, we all play a role in this understanding. And obviously the most important is that we understand what we're screening for. We understand how to educate our parents. And then obviously to evaluate that child and be able to provide them the appropriate treatment that will help them not only overcome these barriers that basically have made it difficult for them to breathe, to sleep properly, and basically to develop an airway. Not to mention the orthodontic conditions and things like that as well. So tonight, sit back, just listen. This will be recorded. You can go back and listen to it. We'll tell you about how to further your interest and your education in this area. But I really want, this is my favorite presentation because you're going to have that aha moment tonight. So I get goosebumps thinking about it. I love hearing people after their reaction because it kind of puts the dots together for you. So I hope, sit back, enjoy, and I hope I put the dots together for you this evening. So we're going to talk a little bit about what this whole sleep issue is about. Currently, the ADA has put together a policy that basically requires dentists to evaluate, screen, and look for basically improper growth and development and improper habits that affect how a child sleeps, breathes, and their airway. So it's really important that we learn what we're looking for to screen. The Orthodontic Society is working on their guidelines, as is the pediatric. So those should be out shortly, and we'll see where those all land. But the bottom line is we should all be screening these patients and looking for basically the underlying root causes that affect a child's ability to grow and develop properly. as well as the habits that can impact that. So when we're talking about what this whole epidemic is about, well, our research indicates that 9 out of 10 children will have one or more outward symptoms. And these outward symptoms are clues of something more serious that basically is the underlying root cause that you, as a dental professional, should be evaluating and then obviously being able to treat. So, what are these outward symptoms? Well, they include a variety of different areas. So, mouth breathing, snoring, tooth grinding, swollen adenoids and tonsils, chronic allergies, eczema, asthma, ADD and ADHD, aggressive behavior, depression, irritability, anger, peer problems, few friends, bedwetting, difficulty in school, especially in the areas of math, science, and spelling, delayed or stunted growth, restless sleep, nightmares, morning headaches, daytime drowsiness, frequently waking up at night, sleep talking, and walking. Now, there are more, but these are probably some of the most prevalent ones that you'll be seeing. And we'll talk about how they relate to each other and what you can anticipate seeing and how do you get this information from your patients. So realizing that this affects 9 out of 10 children, in this tonight, that means that there's 40 million children just in the United States alone that are affected by this. And I know I have some doctors on here from Canada and overseas, and we can give you those statistics as well. But realize this is an epidemic. There are so many children out there that are exhibiting these outward symptoms and not realizing that maybe they're connected and maybe they relate to a more important underlying root cause. So typically, what do parents do? Well, these outward symptoms would basically be a prerequisite for us to visit a pediatrician, maybe to go to an allergist. There are different specialists that we would look to address these individual outward symptoms. And many times the drugs or psychiatric testing or counseling or therapy is what is typically prescribed. And unfortunately, many of these type of current treatment options basically only address the symptoms, not the root cause. And they tend to be short-term Band-Aids, and they often involve several drugs with many side effects. And these can be costly, painful, time-consuming, and also ineffective. So maybe we should take another look and see if we can identify the root causes and also understand that these symptoms are related. Many times the kids might basically exhibit 1, 2, 3, 4. We have sometimes 8, 9, 10. I mean, severe cases, they can represent 17 of these. And it is amazing when you start kind of pinpointing it and saying, this is interesting. Maybe we should evaluate the sleep issues prior to going down the route of other medications that could possibly be prescribed for that child. So research over the past 20 years has linked each of these outward symptoms to a root cause. And these root causes are mouth breathing, narrow palate, improper tongue placement, and jaw relationships. So let's talk about how do we even start screening for these children. Well, there's a lot of visual cues that are available to us. And many of them are kind of easy to realize if you're talking about someone that's sleepy. Well, yeah, maybe I would assume to see circles under their eyes. Okay, that's good. But have you noticed that sometimes we see kids that lurch their head forward? Many times we see kids that, for instance, like this boy on the left, you see their lips parted, a mouth breather. You might see a rolled lip. You see kind of the fullness of the face, kind of looking like a double chin. Look at the profile of the child. Look at how the forehead basically aligns, and you can see the deficiency in the lower third of the face. Look at the lips, parted again. See the rolled lip? Is that lip basically effectually preventing that lower chin from moving forward? because of its placement. Look at the girl on the right. Again, deficiency in the lower third, but look at how the lower chin blends into the neck. Sometimes we call it a funnel look, just because of that blending that happens. You can see her lip parted. You can see a rolled lip as well. So these are some of the cues that you should be picking up before a child even sits in your chair. These are things we can pick up and kind of formulate in our heads. Well, I'm kind of wondering, I'm thinking mouth breathing, I'm thinking probably overjet, I'm thinking that that lower chin is really retrusive. It might be both the maxilla and the mandible. But these are things that we should be visually observing as a child comes in. Now, HealthyStart has created a sleep questionnaire that is an amazing screening device. And the reason being is it presents you with 27 of the most common outward symptoms of sleep, breathing, and airway issues. And the parent is instructed to identify these symptoms that are present in their child, as well as provide a severity guide from 0 to 5, 5 being the most pronounced. So we're already going to be able to see kind of a pattern, what's going on. I would suggest using one parent, and then as we proceed through treatment, we'll ask you to continue having that same parent reevaluate. You'll notice the last question talks about speech problems. Well, yes, speech is related. Think about it, pretty much common sense. If the tongue is not positioned correctly, that means the tongue does not rest in the upper palate of the mouth. And sometimes an easy way to explain it to a parent is to say, when we say the letter N, where that sound ends in the upper palate of your mouth is where it should be at rest. And none of us were ever taught that. And maybe some of you saw a myofunctional therapist, but most of us have never been taught that. So it's a very interesting conversation, because if the tongue is in the right place, you can't mouth breathe. You can only nasal breathe. What if the swallow is not correct? What if the tongue is laying low? Obviously, the tongue is your most powerful muscle in the body. And if it's not able to basically move in that direction or be able to have the endurance to stay in the upper palate of the mouth, pronunciation of words are going to be really difficult. So you can kind of see how that might go hand in hand. And you might see a lot of those kids. So those are the reason why we ask those kind of questions. There was a research study that was done on over 500 children, and it's basically evaluating the HealthyStart sleep questionnaire and what relationships we could see, what were some common factors, what was the most prevalent of those outward symptoms. So the results of this study basically said mouth breathing and snoring are commonly associated with more sleep disorder breathing symptoms than any other symptom studied. 9 out of 10 children had one or more outward symptoms of sleep disorder breathing. 60% of the sample had 4 or more outward symptoms. 1 out of 5 children experienced bedwetting. That was kind of a shocker for me, and this is at a later age. I didn't realize how prevalent it was, but understandably, we don't really talk about it. If your child has this issue, you're not going to be broadcasting it. So a good way of thinking about it is look at a classroom of 20 kids. 4 of those kids are bedwetting. And I always joke about it, but it isn't so funny. When I talk to parents, we'll have that conversation about bedwetting, and sometimes a parent will say, no, he doesn't bedwet because he wears pull-ups every night. Well, a 9-year-old wearing pull-ups every night is not normal. This is something that we should be addressing, and we should be evaluating that child to see if there's an underlying root cause that could be contributing to this problem. So we'll talk about how to present that and how to talk about it so it's not so obvious and it doesn't embarrass the child. I think this last bullet point is extremely important. Between the ages of 4 and 12 years of age, 92.6% of the outward symptoms will not self-correct, and 30% will worsen with age. So that basically means if you see these outward symptoms in young children, it's better to treat it than run the risk of it self-correcting. The likelihood of that condition self-correcting is less than 8%. Does a parent want to run that risk? No. If we can easily solve and be able to address these issues, I think we should take that risk. And this kind of statistic helps a parent when they're evaluating, do I really go ahead and go through with this type of treatment? What am I learning? What are my potential of self-correction is? And what is the likelihood that it's going to remain the same or get worse? So you can give them those kind of percentages. So we said that mouth breathing here is the #1 outward symptom, which represents about 43% of the time. But what makes that interesting is we know that if a child mouth breathes, we will anticipate that they have 7 to 8 other outward symptoms. We also realize that the reason why mouth breathing is so critical is because if they open their mouth just a half an inch, we actually close up the airway by 6 millimeters. So what does 6 millimeters mean? Well, what that means is a 7-year-old has an airway of 7 millimeters. So if they are mouth breathing, they're basically reducing that airway down to 1 millimeter. I'm going to show you how small 1 millimeter is. But that child is trying to get enough oxygen into the body with only 1 millimeter of airway space. That's not enough oxygen. And in many times, it's not enough oxygen for that child to be able to go into REM sleep. REM sleep requires more oxygen. So we'll talk about maybe some of the symbols or some of the visuals that we can aid a parent to kind of express this. But here you can see some of these others: talks in their sleeps, wakes up at night, restless sleep, ADD and ADHD, falls asleep while watching TV. Take a look at these. These are really interesting to see how prevalent they are. As I said, typically if they mouth breathe, we would anticipate 7 to 8 other outward symptoms. And these are many of those outward symptoms that relate back to those children that mouth breathe. So what are the implications of this study? Well, the findings show that sleep disorder breathing is much more common and affects children even as young as 2 years of age. I will even go further. There has been research where they've actually evaluated a fetus prior to birth, and they're able to see a lot of these symptoms already present in those fetuses. So yes, at 2 years of age, we can see it, but I would say always be looking. Many times a child doesn't come into your office until 2 years of age. Well, let me just make one suggestion. If it's your own child, if it's your grandchild, is it your niece, your nephew, it could be a neighbor, keep your eyes open. You'll start seeing it earlier and earlier and on. And we can tell you how we look at children even younger than 2. Obviously, the second is begin treatment as early as possible to ensure permanent changes. Why is that? Well, obviously, 2 reasons. One, we're going to be looking at those underlying root causes, and we're going to be able to actually promote growth and development with the HealthyStart appliances, as well as eliminate the improper habits and create the proper habits with the myofunctional therapy that is built into each one of the initial appliances. So that child, just by wearing it, is getting that type of exercise, as well as continuing with that kind of reinforcement day in and day out when they're wearing those appliances. And the last is identifying outward symptoms displayed in 90% of the children that enter your practice can significantly reduce this epidemic and enable you to successfully treat the overall health of patients. I have a question here, and I'm just going to interrupt because sometimes I want to make sure that I answer whatever you need to answer. So the question is, when is the ideal age to start treatment, and when is it too late? Ideal age is as soon as you see it. Now, granted, if it's a 6-month-old, we're going to have trouble getting an appliance in them at 6 years of age. But our youngest patients, we have 5 that are 13 months, and we have my oldest patient is 84. So I'm always saying, realize our parameters. Obviously, earlier the better. While we catch them while they're growing, we can make more permanent changes. But we can wear these appliances as an adult. I just can't guarantee that it's going to be a permanent change. Which, maybe they wear an appliance every night. Is that the worst thing? No. Are we going to make a big difference in the way they sleep, the way they breathe, their health? Absolutely. Can we straighten their teeth? Yes, we can. So there are definitely benefits. I'm just tonight focusing on the children just because it's such a dynamic to make permanent changes in a child and to catch them at this early age and really with their whole life ahead of them to make those kind of changes. So hopefully that answers your question. So let's, I'm not sure why this is having problems. Okay, here we go. So the airway, let's talk about this and how we address these habitual issues. So remember I talked to you about the airway and maybe some visuals that will help a parent understand that if we're mouth breathing, we're reducing the airway, we can have skeletal problems that also reduce the airway. So maybe talk about the airway being small, similar to a coffee stirrer. And maybe what we can explain is what we want the airway to look like is more like a garden hose. So this is a good visual so a parent can understand how difficult it would be for a child to breathe through a coffee stirrer. So I tried to do an experiment. I actually took a coffee stirrer and I thought, you know what? I'm going to see what these kids struggle with day in and day out. So I decided I was going to spend the whole day breathing through a coffee stirrer. Well, I got through about 10 minutes, maybe 15, but I would be pushing it. And I'll tell you, I had the most massive headache I've ever had. I tried Excedrin, I tried everything, and I couldn't get rid of it. The only way I basically alleviated that headache was to go to sleep that night and wake up the next morning. So I can't imagine what these kids must be going through day in and day out, having that type of reduced oxygen and basically simulating what it felt like to breathe through a coffee stirrer. So I'm not suggesting all of you do this, but see what it feels like. I mean, next time you go to Starbucks, pick up one of those coffee stirrers. I assume they still sell those. I know the straws are banned, but try it. See how it feels. But I would encourage you because you will not believe how difficult that is. So maybe the question is, why are we seeing more and more of these potential problems and seeing more and more children exhibiting these outward symptoms? Well, it stems for various reasons. Many of it is basically due to the lack of breastfeeding. And I always kind of give my 2 cents about this. Be really careful how you explain it to a mom. As moms, I think I can speak that way. I have 3 children of my own. If my child is struggling and someone came to me and told me it was a lack of breastfeeding, I would take that as my responsibility. I would find it very difficult and I would blame myself. I don't want parents to blame themselves. They don't know. I mean, let's face it, in this current age, both parents usually work. It is difficult and it's rare to hear moms that have breastfed for 2 years. Now, sometimes a mom will say, yes, I've done breast milk for 2 years. That's awesome. But what was the mechanics that you delivered that breast milk? It's probably through a bottle. And unfortunately, a bottle, a pacifier, has the same characteristics where it depresses the tongue. It prevents the tongue from being up in the palate of the mouth where it belongs, and it also prevents the proper swallow. And it doesn't allow the oral cavity to develop like it should, with the way that breastfeeding really encourages that development. So understanding, many times we'll ask the parent, did your child use a pacifier? How many times have you heard, oh, until they were like 4, we had to, steal it, burn it, whatever we had to do. You can imagine the impact that that pacifier had on the mouth. So a pacifier in a bottle basically create a suction in the mouth, and that suction will allow those arches to collapse. And so many times we hear children have narrow arches. Well, many times it's because of that. The tongue is now laying low. Until the tongue can create the space to hold it in the palate of the mouth, it's not going to go up in the palate of the mouth. So you're kind of seeing where I'm going with this. So besides the myofunctional therapy that we're going to be providing, we also need to expand the arches, which is really interesting that we can accomplish this in many cases with just use of these appliances. So we'll talk about that in a minute. But I want to talk about the last area that can obviously contribute to this problem, and that's a soft diet. So this is a great example. I love it. Graduate Puffs, the nutritious snack that melts in a baby's mouth. Well, we never use our oral cavity. We do not use the ability to really chew. So how many times has a kid told you, it's too chewy, I'm not going to eat the steak? Well, that's what we did how many years ago? Back in the cavemen, you never saw a lot of these issues occurring, and that's because their diet was completely different. Sometimes I hear people say, should we chew on rocks? Well, I don't think chewing on rocks is the ideal, but you get the idea that we should have a well-rounded diet. These items that we maybe purchase that melt in your mouth, that's not real nutritious food. That has probably an exorbitant amount of processed foods. The texture's not right. So obviously explaining this to a parent, and many times a mom is overwhelmed, but this is just part of the conversation. So again, when we see a child that has something like this, an open bite, you can probably start thinking about maybe an extended use of pacifier or bottle, probably have a tongue thrust, could have finger or sucking habits. But these are all the thoughts that should be coming into your mind of what we're going to be addressing when we start the HealthyStart system. Let's talk about airway and just the mechanics. Understanding the nasal cavity, the hard palate, the soft palate, where the tongue is, where the airway is. And these are just things you can kind of go over with a parent just so that they see how every part plays a function in the development of the oral cavity. And when we talk about mouth breathing, when we talk about the tongue, where it should be, we should also talk about the importance of the nose. Nasal breathing is basically ideal. That's the goal. That's what we're aiming for. So why is that? Well, the nose has 5 functions. It serves as an air passageway. It warms and moistens inhaled air. Its membrane traps dust, pollen, bacteria, and other foreign matter. It contains receptors which sort out odors, and it aids in pronunciation and the quality of voice. So how many times have we seen this? A child exhausted, asleep in their car seat, mouth breathing. These are the things that a parent, we're hoping with our education and explaining what this is, will realize this. I will make a comment. If you didn't get enough of me today, on Tuesdays, we basically give a parent webinar, and it lasts about 45 minutes to an hour, and we educate parents. And I'm always amazed because I feel like there are so many children out there. There are so many parents that just have not heard the word or are not aware of what this is and how to identify it in their children. But I will say these parent webinars, we attract a couple hundred parents. Our largest one was 18,000 in one night. So it's really powerful. We do ask our providers across the country, we love for them to basically get on one of these webinars and really educate their community. And we do a lot of promotion. We talk to different groups, mommy blogs, so that they can talk to their followers in order to be educated and come online. So I just thought I'd bring that up. You're more than welcome to come. every Tuesday night, 8 o'clock. So we're talking about mouth breathing. So let me show you a video that really impacts what we're really talking about. And you can see Eli.
Now he's holding it. That was holding it. He's still holding it. He's trying to take in air. There he goes. Okay, now watch. He's holding it. He's holding it. He's holding it. He's holding it. He's still holding his breath, and he's going to gulp again. There he goes. That was it again. And again. He's holding. He's holding. He's trying. There he goes. So this has been 3 minutes and 15 seconds, and you can see how many episodes he's had of not getting calm breaths in. Now, watch what happens when I take his jaw and I just bring it forward. If I can, let's see if I can. And I open his airway. Just bring his airway forward. Got his airway. I'm opening his airway, just pulling his jaw forward ever so slightly. And now he's breathing through his nose quietly. His mouth is a little bit open, but he's breathing through his nose. This way. You're quietly breathing, you don't hear him anymore. And all I did is gently bring his jaw forward.
Pretty powerful, isn't it? Imagine these children struggling. Maybe you have your own child that represents something similar to this. So the good news is we have developed a system that basically addresses everything that you just saw with Eli. And that is we're basically allowing that lower jaw to come forward, but to come forward in relationship to the upper jaw. So we are promoting that proper forward growth. At the same time, we're repositioning that tongue because, as we know, if the tongue is up in the palate of the mouth, we can breathe through our nose. So we're doing all of this, especially at the time when the child needs it the most, when they're trying to sleep. So this Eli, it's something you won't forget, and it is very powerful to a parent as well if you're explaining it and what these children are experiencing. Another really powerful tool to use is basically showing what is going on. So if we look at the case on the left, you'll see that and these are two different 5-year-olds. So the case on the left is actually a restricted airway, and the one on the right is what we would consider a normal airway. Now we have to be a little bit careful because this is obviously a Ceph. We can also use a CBCT scan to look at this. But please remember, we're only as good as our tools. And these tools are basically taken in a vertical position. And as we know, when a child sleeps, the muscles will relax and the airway can even close further. So about 21% of your patients are going to exhibit this type of skeletal airway problem. Even if you have a child that exhibits a normal airway, doesn't necessarily mean they're out of the woods. And that is because they could have a habitual problem. So knowing that 9 out of 10 children exhibit one or more outward symptoms, and realizing that only 21% of the population is going to have a constricted airway in a vertical position, that would mean that there is a large percentage of kids that have habitual problems that are creating those outward symptoms of sleep, breathing, and airway, as well as interfering with the way and the process and the amount of oxygen that are entering the body. So here on the left, a normal, this is the same child, a normal airway. Look what happens when they mouth breathe. Just opening it a half an inch restricts the airway, and it closes it down about 6 millimeters. So important visual to take in. Remember I told you when we looked at the coffee stirrer versus the garden hose, what does actually a millimeter of airway look like? Well, let's take what an ideal is. This is a 7-year-old boy, kind of a funny pictures, but this is a 7 millimeter airway, so 100% airflow. That's what we would anticipate in a 7-year-old. Now, if he mouth breathes, we're going to reduce that 7 millimeters down to 1 millimeter. Take a look at what that looks like. That's a visual. So that's an important concept to understand what we're talking about. 7 millimeters, you know, we throw out all these numbers, and unfortunately our parents, they are very astute, but the visual is really going to help them understand. This is a great case, and this basically shows you where we're going, and this is extremely exciting. I hope you feel the same way. I get excited just to explain it. So when we look at a child, when we're looking at a CBCT scan, and you know it's an expensive piece of equipment, and you have one, great. If you know someone who has it, maybe you can send patients over to them, but it's not necessarily, but let me show you what it can demonstrate in a patient. So when we look at a CBCT scan and we're trying to understand what is a normal airway, what the typical way of determining what that normalcy should look like is we take the age of the child starting at age 5, multiply it by 10. So if we have a 9-year-old, we would anticipate seeing 9 times 10, a 90 square millimeter airway. Well, this example here is a 9-year-old, and unfortunately his CBCT scan only shows 53.6 square millimeters, which means that basically he's compromised. So during the growth of a child, we know the airway will grow up till age 17. At age 17, we basically hit our peak, and that would be an airway between 150 and 170 square millimeters. So here's the bad news, guys. At age 21, our airway starts to deteriorate for the rest of our life. So we've had many conversations where we'll say, wow, that adult has sleep apnea. The airway is only, you know, X number. The problem is we never know if they actually reach their full potential, or maybe the conversation is that 150 to 170 not enough to last us for the rest of our lives? Well, let me show you what happens just with 1 month of initial treatment with the first appliance in the HealthyStart system. So the patient is wearing the habit corrector, which is the first appliance. You'll see it in their mouth. They wear it for 1 month, and this is what this child's airway came back at, 337 square millimeters. Not only is that 6 times greater than his initial 1 month prior, but it is double the airway we would ever anticipate at the peak of adulthood. So just take a moment and just gather that. So maybe if we can promote the growth and development in these children, we can develop an airway that's far greater than what we would even consider our goal in adulthood. So what would that mean for the rest of their life? Would you anticipate better health, better longevity? Very likely. So these are the questions. We are now involved in about 6 major research projects, and this is what we're going to be looking at. I mean, this is the excitement going forward. We have so much to discover, and I am just thrilled to be on this journey. So this is part of my aha, woohoo, this is unbelievable moment. So here's a little bit, here's just a diagram of what I just talked about, and you can see the changes that occurred in that patient. So let's kind of review what we had talked about. So we know that mouth breathing and snoring are very critical, and they're usually a result of extended bottle feeding and pacifier use, poor tongue position and abnormal swallowing. Could be a result from sugar processed foods, poor oral habits, thumb, finger sucking, lip sucking, tongue thrusting. And the mouth breathing and the snoring can basically create a compromised airway. And what does a compromised airway create? Well, reduced oxygen, reduced airway, affects the brain function, immune and endocrine system. It creates swollen adenoids and tonsils, low tongue position, tongue thrust, underdeveloped dental arches, overjet and open bite, as well as cross bite. And this compromised airway will lead to what we call sleep disorder breathing. In the dental world, they've now created sleep-related breathing disorders, but it creates these outward symptoms such as restless sleep, ADD, ADHD, bedwetting, chronic allergies, nightmares, daytime drowsiness, aggression, defiance, difficulty in school, frequent infections. We do have a quick question. It says, once a child reaches an airway opening of desired square millimeters, do we stop their appliance or is the appliance permanent? A great question. So we're basically developing that child. We're going to be watching him and going through his development, not only to change the habits, but also promote it. So as the child is developing, and we'll talk about it, usually we use age 12 as kind of the line in the sand that kind of talks about no more further growth or very reduced further growth. And those diameters are going to kind of change. So we're going to basically provide a treatment that's going to get them up to age 12. And this can be in a different, I'm going to go through the different series of appliances, and active treatment lasts about 1.5 to 2 years. And then we'll see that child maybe every 6 months at their teeth cleaning or something on that order, just to kind of maintain that all the dentition is coming in appropriately and in alignment. Because we'll go on to explain that orthodontic conditions that we see, such as crowded teeth, instead of looking at crowded teeth as a cosmetic change, we're going to be looking as crowded teeth. Oh, if there's crowded teeth, they probably have a narrow palate. If they have a narrow palate, they probably don't have enough room in order for the tongue to be in the proper position. If the tongue isn't in the proper position, it's probably laying low. If it's laying low, it's probably creating mouth breathing. If we have an overjet condition, does it mean the upper teeth are too far forward? Not necessarily. It typically means that the lower chin has not had the ability to grow and develop as it should. Interesting, we've done one of the largest orthodontic studies with the HealthyStart appliances, and we actually promote 54% more lower growth than we do in a control sample. So we're going to be promoting that growth and development. Habits, obviously we talked about that a little bit more. What if we have cross bites? Cross bites actually are going to be rectified. Again, restriction of the arches, it basically is related to sleep issues. So we're going to start talking about that, and then you'll see that even though we've maybe gained that proper airway, and that example had the appliance in the mouth, we want to make sure that that whole underlying root cause, all of those issues that we're addressing, is basically going to be the greatest growth and development we can get in that child in the oral cavity. And we want to make sure that what we have changed is a permanent change rather than something that's going to relapse. So that's why we follow them through that growth period in order to make sure we accommodate that. So hopefully that answers your question, but keep having them come. It's great to see these questions as we're going along. So how does sleep affect brain function? Excellent. Here was the study that was done that basically looked at through an MRI, the brain activity or the brain function that occurred. In the top 3 images is after a normal night's sleep. So you can see the activity that occurred. The lower 3 images are basically with 1 night of sleep deprivation. it's really hard to see any brain function. I mean, look at this down here, just a small, minute area. So you can see the dramatic changes that happen within the body just by missing one night of sleep. So let's talk about what we can do. All right, so we've identified the problem, we've screened the children. Now we're looking at the underlying root causes. So how do we start this? Many of you probably have never seen a child that's 2 or 3. Maybe you have, but you were like, oh my gosh, we've cleaned their teeth and that's about it. Or maybe as an orthodontist, you understand all that growth and development, but now I realize the problem. I don't want to wait until they're 8, 9, 10 years of age. I want to do something as an early phase 1 or phase 1 plus, where we can get in there and promote that growth and development. So let me tell you about HealthyStart and what we can do. So today we're a company, Orthotane. Many of you have probably heard of Orthotane. We've been around for a long time, over 50 years. And we've treated over 4 million children. So we've done a lot of research. We've been so involved in growth and development of young kids. So we are ecstatic as we see the consciousness that has occurred in the last few years about sleep, breathing, and airway. We actually, as I said, we've been around for over 50 years. And it was during a study that we were doing in Italy, very large study, and we actually had, questionnaires. So the kids were, the parents were, oh, beautiful teeth, this and that. But so different things we noticed with our child. For instance, they're doing so much better in school, or they've now become the fastest person on their track team, or their personality changed so much that they tried out for the school play. They were so shy before, and now they seem to have come out of their shell. Well, before this study, we always thought, well, straight teeth promotes confidence in a child. And when a child is more confident, maybe they participate, they do better, they socialize more. But when we started seeing the predominance of these comments, we started investigating. And what we determined, which was the first start, was we were changing mouth breathing into nasal breathing. And that was the first step in this long journey that we've been on. And the journey's not over yet. Obviously, we have a lot more to go, but we're certainly understanding a lot more that's going on than we had ever before. So kind of understand that. It kind of makes sense when you start looking at this, and maybe you're sitting here thinking, oh my gosh, day in and day out, I see one kid after the other that exhibit everything you're talking about. I hope you're seeing that, and I hope you realize that. So here is kind of the gamut of what HealthyStart is. So we have different tiers, basically meaning when the age of that patient that comes into your office will determine what series of appliance you'll be using. So let's say you have a child that comes into your office at age 5. What are you going to be looking for in regard to the HealthyStart treatment? So you would go into the HealthyStart Kids, and that's typically from age 4 to 7. And these are the typically three appliances that you'll be using. We'll talk a little bit about a class 3 condition, and we call max A, meaning that deficiency in both the upper and lower arches. But let's start with basically what we consistently would use as treatment. So the first appliance would be what we would call a HealthyStart's Kids Habit Corrector. And it does exactly what its name says. We're going to first focus on those habits. We're going to convert that mouth breather into a nasal breather. We're going to start expanding those arches. We're going to create the position of the tongue. We're going to create that myofunctional therapy that is built into each and every appliance. So it's activated by the child swallowing. So all night long, when that child is swallowing, that proper position continues on and on. At the same time, we're going to bring the jaw in a forward position in line with the upper arch. And what it's going to do is, one, if it needs to be moved forward, it is going to be moved forward. If it's already in a proper alignment with the upper arch, it's going to prevent it from slipping back. As we showed, if a mouth breather, we see that lower chin drifting back. So it's going to do all that at the same time. Now, once the permanent teeth start to erupt, we want to capture those permanent teeth and make sure we're guiding them into place. So we're going to use the eruption of teeth in order to continue the expansion of the arches. Because as we capture that tooth erupting, we're ensuring that it erupts in straight, put natural pressure on the adjacent teeth in order to expand the arches and accommodate the tooth, but then also do what nature should have done. When we go from the transition from primary teeth to permanent teeth, we expect 4 millimeters of expansion. And guess what? We're going to get it. We're going to create the situation with the use of the appliances in order to guide and create that ability. At the same time, these appliances are going to correct any overbite, any overjet, open bite, gummy smile, class 3, cross bite, gummy smile, all just with passive nighttime wear with this appliance. And then once the laterals start to move, we'll look into the third and final appliance where they'll use it more of a retention, but also we're going to guide the rest of the incoming teeth in prior to age 12. So you can kind of see how this progresses. Wow, I've got more questions here. So let's answer a few questions before we go on. It says, again, the same kind of question. Once a child reaches an airway opening of desired millimeters, do we stop the appliance or is the appliance permanent? It's not permanent. It basically is going to be used to maintain it until about age 12. The second question, how do I get my toddler to stop sucking their thumb? How do I get her to wear the habit corrector? Great, great question. So we get about 96% ability to switch from the thumb to the appliance. And I'll tell you a couple things, I'm going to give you my 2 cents. So when we see a child who's thumb sucking, I always say be very careful, because for whatever security reasons, I think there might be an additional area. We're interesting creatures. When we have a deficiency, we try to compensate for that. And I think sometimes we see kids sucking their thumbs because they feel they can get more air. Now, ask that question, when does that child suck their thumb? Typically, the response is going to be at night when they're going to sleep, or if they're tired, they're watching a movie. So these are great opportunities to substitute. We never say we're going to eliminate, you can't suck your thumb, we're taking away a pacifier, any of those. We basically say we're going to substitute. And this way, every time you go to put your thumb in, put this in. Believe it or not, these appliances are soft, they're squishy, they feel better than the thumb. Sometimes I'll say, think of it as a pillow for your teeth. Have that conversation. How does it feel when you go to bed? What is your favorite thing? How does that pillow make you feel? And then ask them, what if we could give you a pillow for your teeth? What do you think about that? So we'll have those conversations to talk about how you substitute a thumb for the appliance and how we increase your success. We do treatment plans for you to help you, especially at the onset, because this is a new area. We have experts that basically can help you with each case, and we'll give you those kind of guidelines. We'll give you some of those tips. We have a digital series that we'll talk about. They will also help you with these tricks of the trade. So we have a lot of a lot of years, a lot of working with children, and we feel that we're pretty good with our cooperation. So let's kind of go over the HealthyStart addressing the root causes. Again, we're going to expand the dental arches. We're going to establish nasal breathing. We're going to train the tongue. We're going to eliminate bad habits. We're going to advance the mandible to correct the overjet. We're going to encourage the proper facial growth and development, and we're going to correct most orthodontic problems. So a habit corrector. We talked about that. I had mentioned that it basically has built-in myofunctional therapy. So what is that all about? Pretty interesting. So here's what the habit corrector looks like. And it basically has the myofunctional therapy built into each. So here are the features. We have these expansion tabs here that basically allow the tongue to flatten and create the expansion, create the place for them to place their tongue. We have these little prongs here that are going to prevent the tongue thrust, but it's also going to indicate to the tongue when to retrieve it back. We also have a lingual shelf. It's more like a ramp. So every time the child swallows, that tongue is going to go up the ramp to the position in the upper palate so that it is in the right position. We're going to train it to stay there. Also create the endurance of it staying there. At the same time, you'll see in the lower portion, there are these tabs that prevent that lower chin from being able to drop back. We also have appliances that have pads in it that will help close that open bite. Remember, we saw the children that have the open bite due to pacifier use or thumb sucking or finger sucking or any of those. How do we determine if a child has a proper swallow? Well, a proper swallow basically can be observed, especially when a kid maybe drinks a glass of water. You can put a cup on the operatory table and then allow that child to just take a swallow of water. I wouldn't tell them you're going to be observing them swallow, but we want to basically see the movement they make in order to swallow this water. So typically we only see the lower portion of the neck move when we drink water. If you see a child use any of the facial muscles in order to swallow it, you can be assured that they have an improper swallow. So for instance, they take a glass of water and you'll see them using their lips to try to get that water down. That's the easiest way. And even when we're doing our treatment, every time a child comes in, I would have them take that sip of water, just seeing how the progress is being made with the use of the HealthyStart appliances. So remember I told you about the built-in myofunctional therapy that happens with every swallow. So the reason why we get so much correction, especially early on, is because when we swallow 2 times a minute during the day, 1 time a minute at night. So by wearing this just at night, we basically repeat that swallowing almost 500 times each and every night. So that's a lot of repetition, and that's going to create faster change and obviously more permanent change. We have a very interesting research study that's coming out. It evaluated over 200 patients, and it basically wanted to see in the first 5 months how many and how much, what was the degree of change or improvement that we saw in these habits. So let's take the first one, headaches. So out of 220, we had 18% that exhibited headaches, and that was about 40 children. And out of the 40 children, we saw 98% of the cases having improvement. The mean correction of those improvements was 94%. The mean correction of the entire sample was 91%. And the percentage of cases with 100% correction in the first 5 months was 85%. So you can take a look at all of these different outward symptoms and what was the percentage of correction in the first 5 months. So ADD and ADHD, this is a really interesting conversation. Obviously, we all know what epidemic proportions ADD and ADHD has on our pediatric population. So many kids we hear are on medications. If you hear they're on 1 medication, they're typically on 3 medications. How often have you heard my child is on the full dosage and we still haven't seen improvement? So the interesting, obviously, ADD and ADHD is not a blood test that's going to determine whether or not they have the condition. It's rather a series of criteria that is evaluated and basically determined if that child exhibits that criteria. Well, guess what? That criteria is the same criteria we use to look at sleep disorder breathing. Can they be misdiagnosed? Absolutely. The most recent research shows that the children with ADD and ADHD, 85% had sleep issues. So the question is, if you suspect or a child exhibits ADD and ADHD-like behaviors, investigate sleep first. Let's see where the child lands. Let's see how much is sleep contributing, or maybe sleep is the contributing factor to these outward symptoms. So when we talk about it, I want to basically give you some information because it's always important when parents ask you. Probably the largest study that was done on children with ADD and ADHD was by a woman named Karen Bonnick. And she basically looked at over 13,000 children. And she found sleep disorder breathing increases the risk of ADD and ADHD by at least 50%. ADD and ADHD patients have little or no REM sleep, but have delta sleep. Important. Patients without ADD and ADHD have primarily REM sleep and delta sleep. In the study that we conducted, we found that ADD and ADHD was present in 25.2% of the cases. So these are disturbing statistics. So what are the long-term effects of ADD and ADHD? Well, children that have been diagnosed with ADD and ADHD, 50% are held back 1 grade, 30% are held back 2 grades. I got news for you. That child is suffering from sleep disorder breathing. I could hold them back 10 grades. It's not going to make a difference. They're still going to have those same issues. So again, importance, get to the root cause. Let's see what's going on. There was another study that found that children with sleep disorder breathing revealed that they had 10 to 20 reduced IQ points. 10 to 20 points. In my world, that would be college or no college. They went one step further and said, let's give a monetary value for what an IQ point is worth. 1 IQ point is worth $170,000 during the lifetime of that child. So there you go. That's another. So let's talk about HealthyStart promoting growth and development. So as I said, the question was, how long do the kids wear these appliances? Where do we feel that the cutoff is where we make more permanent changes versus maybe having to wear something more on a nightly basis? So typically it's age 12, and the reason is when we look at normal craniofacial growth, we see that a majority of the craniofacial growth is completed at age 12. So at age 12, we see 89% in male, 94% in female. Also interesting to note, look at the growth. What is the natural growth and development? Downward and forward. So this is what we are hoping that we're promoting, and that we're promoting the natural growth and development, what nature basically intended for these kids. So let's take a look at some patients. So as you can see, here's the initial of a 5-year-old, basically underdeveloped jaw, lower third of the face, lips parted, severe overjet. This child had a lot of sleep issues. This is basically a 1.5 years later with growth and development. So the mandible was basically promoted 54% more growth than in the control sample. And you can see in this case, the amount of forward movement that occurred in her case. I did mention I was going to talk a little bit about what if we have a class 3, what if we have both the deficiency in both the upper and lower arches. We have interesting appliances that can address that. And again, it is interestingly designed where there is no front wall to the appliance. And there are 3 tabs that basically the tongue is directed to push against these tabs. And as it's pushing, the upper arch has free movement to move in a forward direction. And then the lower portion brings the lower arch along with it. So we're able to move both arches in a forward direction. And you can kind of see in this case, the initial 1-month progress and current. Class 3, same kind of idea, except we will have a lip bumper on the lower portion because we're trying to anchor the lower so we can actually drive that upper arch and make that jump. Once they make that jump, obviously we kind of restart the growth and we see normal movement, and we'll move into then the habit corrector. You can see this case right here. Again, we typically ask them to wear it 2 hours a day. where they're going to be pushing on those tabs in order to drive that. It is very quick. It takes anywhere from 2 to 4 months. It is a fast moving. We actually had one case that actually was able to move the case over a weekend, but the child wore it 23 hours a day. So treatment planning. We do look at each and every case that you submit. We will go through it. We will help with the clinical, the treatment planning of the case. We want to kind of be your consultant in your office. We want to make sure that we're looking at each and every aspect of that case to make sure and to determine the usage of the appliances when they come into effect. What is the best timing for that case? So it's a great learning tool for you. So let's look at some cases. That's always the fun part. So here's a child, age 7. Obviously, look at their screening device, this HealthyStart sleep questionnaire. You can see all the 4s, the 5s, quite a few symptoms. I can't remember exactly. We're running late, so I think it's 17 that he had. You can see after a 3-month period where they have gone down to basically 0s and some 1s. So pretty successful. Notice sleep patterns. This child very delayed in speech, didn't say many words up until age 3 or 4. So you can see the connection that happens. So here's the child at the onset. This is in March of 2015. Take a look. Serious, very, very deep bite. You can see circles under their eyes. You can see the square lower arch. We want a rounded lower arch. And then wearing it just passively at night while the child sleeps. Obviously, we've corrected the habits that he had. Take a look at now, 1 year later. Look at the overbite correction. Look at the lower arch, nice and rounded. Look at his profile. His face looks so different, doesn't it? How much development has occurred? And now let's look at what his final look like. So here you can see beautiful dentition, nice round. Look at the nice round upper arch. You can also see how all the teeth settled in. It looks perfect. Here's another case. Again, you can see the 4s, 3s, 2s, 5s in this, and you can see where they went down typically after about 3 months. You can see the initial, you can see the progress, how much correction is being made in the case. Here's another case. You can see, obviously, a lot of spaces. The midline is off. Deep bite. Here, hers finished. You can see from beginning to end. Let's take a look at another case. You can see how it looks like. Deep bite. Here's the appliance in the mouth. Here are the incoming permanent teeth. They're going to be captured by the appliance. They're going to be directed, aligned, expanded, and here's the finish. Here's another case, beginning to end. Another case, beginning to end. You can see this girl, interesting girl. The mother had surgery later on in life. She recognized the problems that she had a child in her young child. Deep bite. You can see square arch. You can see the circles under their eyes, the deficiency, the rolled lip. Here she is during active treatment. Such a change in her facial. Look at her arches. Look at her dentition. Now let's see what it looks like after we finish and what's the retention like. Here she is. Further down, you can see the maintain, how the case maintains very nicely. Another child presented with snoring, bruxing, bad breath, ear infections. Here he is 1 year later. This actually happens to be a patient out of Alaska. Another case, same thing. You can see 5s, 2s, 1s of different outward symptoms. You can see the deep bite. You can see the misalignment, crowded here. And this is what they are basically about a year later. You can see the square arches, the roundedness of it, and how the teeth just basically are coming into space. Here's a child, had a spectrum of issues, snores, brucks. Mid-treatment, final. 14 years later, how it maintained. An interesting feature we have, all appliances come with an app. The app is wonderful. It helps track compliance. It will help the patient. Every night they wear the appliance. They wake up in the morning. App will ask them, did they wear it all night? Did it stay in all night? Yes, yes. They get 30 minutes of game time. They get a coin for every day. They deposit it into the bank within this town. They accumulate points. They can buy treats for themselves, gifts. The mom is also asked, or mom or dad, whatever parent filled out the initial sleep questionnaire, and it will continuously every day ask them if any changes have been made so that they'll be able to track it. Every Friday, we ask them to take a selfie. They will be provided cheek retractors, so we take a selfie for them. Within the parents portion of the app, it will be like a flip book. They can share it with other parents. They can tell them about it. It's a great way to go back. At the same time, all of this information is also stored so that you as the providing doctor will also have access to it so that you can monitor that case during the time that you are not seeing them in your office. So a great tool to utilize. Again, 4 million cases worldwide. We take safety extremely seriously. All of our appliances are regulated to a Class 2 medical device. We do not need to do that. Our appliances are safe enough that you can actually put it in the body of our child. We obviously wouldn't do that, but we want you to understand how seriously we take safety of your child. Realize that it is FDA cleared. There's no latex. All appliances are BPA, BPS free, phthalate free, no silicone. I think I have 2 more questions here, so I know it's getting late. It says, how would you test a child for sleep disorder breathing, sleep study? So a very important question. So let me just explain the rules of the road, so to speak. So you as a dentist are not allowed to diagnose sleep disorder or sleep apnea. You are allowed to screen for sleep. The only people that can make the designation of sleep apnea is a MD, a sleep physician, and it's usually after either a clinical sleep study test or a home sleep study test. But again, you as the dental professional can screen for sleep, and that's where the sleep questionnaire comes into play. Now, you are not going to be treating the sleep. You're going to be treating the underlying root causes of basically improper growth and development and habits. Now, if we see a couple scenarios prior to us beginning treatment, is going to basically refer that patient out. And I'll tell you what those conditions are. 1, if you see tonsils that are kissing or touching, and I always say, don't just evaluate your patient in the vertical. Remember, we talked about when they sleep, when you're in the horizontal, it relaxes the muscles, and if there is going to be touching of those tonsils, it basically will prevent that airway for having access to the oxygen they need. So we will refer that patient out to an ENT. The second is if a child cannot breathe through their nose. So we do a simple test, a little game. Seal your lips and breathe through your nose. Typically, if they cannot breathe through their nose, it'll take about 3 seconds for them to gasp for air. If they have difficulty and they cannot breathe through their nose, definitely refer it to the ENT. And it's basically the ENT will look at them. Even if they have surgery, you want to always make sure that you continue or bring them back in to continue through the HealthyStart treatment. Because even though you have eliminated the blockage of maybe swollen tonsils or eliminated the difficulty breathing through their nose, you have not addressed the habits, and that mouth breathing is going to be critical. 80% of the ENT surgery, tonsillectomies, adenoids fail because they do not continue addressing the habitual issues that are present. So just take that into effect. The other issue is on the sleep questionnaire, one of the questions says, does your child stop breathing for more than a minute? If the answer to that is yes, definitely refer them out to a sleep physician. So those are kind of the 3 areas that you're going to be looking for. And you need to make sure you explain to a parent that you're screening for sleep and you're allowing those outward symptoms to be clues of a more serious underlying root cause that you can address. So that's how I would talk about that. So someone asked, what is the cost of the appliances? So typically, obviously, we don't dictate how much you charge a patient, but I would say on average, I hear anywhere from about $3,700 to probably $4,500. And that is if you are using HealthyStart from beginning to end. And typically, it will take you through age 12. The typical time that the treatment would occur in your office is about 3 hours. Out of those 2 to 3 hours of appointments that you would have during that period of time, about 1/10 of it would be designated to a doctor. The others can be staff driven. Now, what is the cost of the appliances to the doctor? Your lab fee, meaning that it would entail all the appliances that you need, the diagnostic services of the appliance, a progress check, the basically ability to supervise and help you. The app that comes with every appliance is a $600 to $700 lab fee, and that includes everything. So hopefully those answer your questions. I thank you. It's been awesome. I am so sorry I ran late, but great questions, and I think those were important. But I think at this point, I'd love to turn it over to Susie. I want her to explain a little bit about what's the next step. How do I get involved? What is the opportunities for me? And how do we continue this learning experience? So take it away, Susie.
Yeah, thank you so much, Leslie. And thank you so much for the amazing information as well. So always the next question that we hear at this point is, how do we get started? How do we get involved? So I'm going to tell you a little bit about that. So our digital education platform is, I think, probably the most popular platform that's offered. And as a matter of fact, even the ADA, who has taken our course, actually said that our course was ingenious, which is fantastic. So we actually have a course coming up April 1st, 2019. The fantastic thing about it, the digital education course, is you can take this course from anywhere in the world. Everything is recorded. Everything is digital. And the way that it works is, basically, on Monday morning, I send you guys a video. You have the whole week to watch the video. And then on Friday, we have a live study club. The study club is great. And the one thing that I love about this course is that it's inclusive. It includes you and your entire staff, because we understand the importance of ensuring that your staff is on board, they're excited, they know what you're doing. And believe me, when they learn this information, they're all in. I mean, they want to help these kids. They want to see these kids improve, and it's so rewarding for them and your entire office. So we want to make sure that, they understand and they get it as well. And in these study clubs, we actually have specialists that join us to talk about things like billing, how to grow the community and let the community know what you're doing. There's so many different things that we go over in that study club that is fantastic for both you, the doctor, as well as your staff. So the course, we have a course that starts April 1st. It's a 6-session digital education course. One of the most important things that it includes is 2 free cases. So I'm talking 2 entire systems. So the systems that Leslie was just talking about, 2 of those actually come with the course, because we want you to simultaneously treat 2 children while you're taking the course. It's a fantastic way to learn. This way you can start these 2 kids in the habit correctors. I'm positive after tonight you already have children in mind that need help. So you can get them started immediately with the habit correctors. While they're using that habit corrector, you'll start the course, and then we'll take you through that entire case as you're taking the course. So it's a great way to learn. But it does include the treatment plan. It includes all the appliances you need. It includes the specialty appliance cases, little animal cases that you can, the children can put their cases in. It comes with the mobile app. And so it's potentially $7,400 worth of savings for you guys, or return on investment for you guys, just with those 2 free cases. You receive a $3,000 voucher to attend any of our destination courses. So not only are you going to get the digital course with the with the interactive study club, you're also going to get to come to one of a live course, because, we feel like, everybody learns differently, and if you can attend both ways, it's fantastic. And you're going to retain a lot of information, of course, in the digital course, and then when you come to the live course, you're going to have the information again, and you'll retain even more. It's just a great way. We actually have 2 courses that are coming up really quickly. We have a Denver course that's coming up February 22nd and 23rd, and we have a course in San Francisco that's coming up March 3rd and 4th. So you could actually join the digital course, and then you can attend those 2 or one of those live courses as well. You also receive an acrylic stand. It actually comes with sample appliances for your office. It's also fantastic, because when you have something like that in your office and parents see this and they can feel the appliances, it's just a great way to get them to start asking questions. They want to know what you're doing. As I mentioned, the ADA actually said the course was fantastic, but the other thing about it is that policy that Leslie was talking about earlier in the presentation. This course actually complements that ADA policy. And as you know, that policy says that every oral physician should be assessing children who have this issue, who have sleep and breathing issues. We give you the answer, we give you the treatment, and it's really up to you. The ADA says it's up to you to get the education that you need, and we supply that education as well. So on top of that, you also receive training on pediatric treatment of sleep-related breathing disorders and how to identify it in your patients, how to use HealthyStart to increase your patient flow. As I mentioned, this course includes you and all of your staff. You receive 18 CE PACE credits and 16 more when you attend the destination course. So great way to get the year going and get your credits all taken care of. So I want to tell you a couple of things that we've heard from some of our doctors around the world. We had a doctor who attended in Australia. He said the digital course was excellent. All at HealthyStart have really got their act together and offer resources others strive for but rarely achieve. Well organized, passionate, and supportive. Doctor in Canada, I want to thank you and your colleagues for this amazing course. I've been searching for a solid system to help my patients, and this is by far the best, most organized, comprehensive course I've taken. Doctor in Colorado, I've really enjoyed the course. We have identified quite a few patients that will benefit from HealthyStart. My business partner's 4-year-old is in the habit corrector because he has had swallowing problems, and we have already seen great improvement in his eating. We already have 3 more patients ready who will be starting next week. We can't wait to see their progress. I love that particular testimony because this doctor was only 3 weeks into the course. As I mentioned, it's a 6-session course. She was 3 weeks in, and she already had patients that were lining up at the door. And that's really how it works. I mean, you start out with those 2 free cases. You get 2 children, they're feeling better. Their parents are excited because they're seeing a change in their children. And next thing you know, word of mouth spreads, and you have parents that are contacting you because they want to get involved. So what is the startup costs? So typically, it's $3,400 investment for the digital course, and then another $400 to attend our destination course, which is a huge deal, fantastic deal. When you get those, think about those 2 free cases that you're getting, and all of and only $400 to attend the destination course. But tonight, we appreciate you guys being with us, and we're actually offering the digital course for the $3,400, and then you can attend the live course at no cost. So we're basically giving you that $400 on us as your promotion for being with us tonight. So it's both courses for the price of one. Register today, and we will actually send out your habit corrector appliances and for your 2 free cases, along with a welcome package via UPS or FedEx, so that you have it in your hand. So how do you get going? couple different ways. One is you can actually visit www.openairwaydentistry.com. You can register electronically. There's a green register now button right on the website. You just click that button, and it's going to lead you to a sign-up form, and there's a discount code field. You just type in the word Airway, and it'll give you your $400 off, and that way you're all set and you're ready to go. We have your information, and we can get your appliances out to you. The other way is you can actually email me directly. That way, if you have questions or if you'd like a little more information in reference to the sign-up process, my email address is slafredo@thehealthystart.com, and I can help you get set up as well. So either way, I always like to say don't wait. The time is now. I mean, this is such an issue. I know that you guys know that sleep, breathing, airway issues is the topic. It's what everybody is talking about, because I think we are now realizing that there are so many children who are affected. And as Leslie said, 9 out of 10 children who are affected with more than one symptom of sleep-related breathing disorders. It's almost one of those things where once you know this, you can't not help. So, we would love to have you as a part of our team. We have the treatment, we have the answer, and we'd love to have you involved. So I hope that you reach out, and if anything at all, first of all, visiting and get signed up and get ready and get going. But if you have questions, email us and let us know. We are here. We are ready. We love to hear what your feedback and what you have to say. I see that there's a couple of questions, so I'm going to click right here and just see. Yes, actually tonight you receive 1 CE credit, and we'll actually be sending that out to you, so you'll receive that via email within a couple of days. So you'll receive that pretty quickly. And then there's one other question. Let's see. The screening sheet. Well, and Leslie, do you want to? Do you think that you can pipe it out? So we have a doctor who's asking if there's a way that she can get the screening sheet emailed.
Sure. We'll be more than happy to send you the HealthyStart sleep questionnaire, and you can take a look at it, use it in your office. We would love for you to start screening right away. And obviously, I hope you take the course so that besides screening, you're being able to address those issues in your patients. So hopefully, I know it's late. I thank you so much, Susie. It was great information. I hope we see you all on our digital class. It's a great experience. Come join HealthyStart. Be a part of our forums. Learn from each other. We have great providers, and obviously, we're on a mission to start addressing these issues in children and make more permanent changes in their life.
Awesome. Thank you so much. Thank you, Leslie, for being on with us this evening. And doctors, we appreciate your time as well. Thank you so much. If there's anything you need, please reach out.